I think it was a real marathon to keep you waking up until that time. Anyway, we have coffee soon, but this particular time it will be an eye-opener because, and that's what I like again in this meeting that we're doing, we're telling the truth. So by telling the truth, we're going to show you disasters or problems that we are faced during cataract surgery, and we are all welcome to participate. Guys, I'm just clicking, eh? Okay, I'm doing that. And hopefully my adventure will start. And this is an adventure of cataract surgery, 4 cases which I think you all need to criticize. This is a standard case. As you can see, I don't have a femtosecond laser. Is there any comments from anybody about how we do the capsulorhexis? Anything different, Bruce?
It's a little small, maybe. I don't know.
Yeah.
So what is a nice tip is to use the entry site size, because that's always the same as a scale bar when you're doing your capsulorhexis. And because pupil size varies, corneal size varies, but the entry site is always the same. And that's a helpful thing. But
absolutely. Very, very good. A skilled eye just pick up the beginning of my problem. It was a small rhexis. And because it was a small rhexis, I tried to keep everything central, which is not a bad thing necessarily, unless you end up with problems. So anyway, a small rhexis, but a rounded one, really nice, okay. Standard full chop technique, high power, not a very dense, I would say probably 1+ or maybe 2+ lens. Everything goes smoothly, or at least that's what I was supposed to think. And then came the epinucleus. Again, I didn't want to go too much in the periphery, so I keep everything in the center. And this is me cursing, as you can say, that just put it out. Something happens there. And you can see that clearly now, that I just punch the posterior capsule. So, what we do now? Vincenzo.
Well, I think luckily you have removed most of the cataract. So, sorry, what is it?
In this case?
Yes, in this case. So I think you've got several choices here. I can't really judge if you got vitreous already there, but you should look at your tear, see if it is round, if it needs completing, and if you can either tamponade with some viscoelastic, and then proceed with very gentle IA. Or if there is vitreous, I think you are bound to do a limited anterior vitrectomy.
Bruce? Sorry, yeah?
Can I just ask a question more than make a comment here? So at this stage, some surgeons are advocating leave the irrigation on in the eye and inject viscoelastic through the side port while the eye is, don't let the chamber collapse. Is that something that...
This is exactly what, I mean, I did the irrigation on, as quite rightly said, and at least in this case, my first mistake was managed, I think, better when I have the complication. Maybe we need complications. So the next step, as you quite right say, is leave the irrigation on. You don't take the phaco out, and then you put viscoelastic in. Trying at least to make the loss as less as possible. So now you can see this is my problem. As you quite right said, I still have some job to do in the periphery, but at least I don't need to call Paris from the clinic, at least not that day, to assist with the nucleus being in the vitreous. So, at least not that time, Paris. So we wait. Now you can take both instruments out. The reason that you don't take the phaco tip out is that you want to keep the AC exactly the same. If the anterior chamber stays stable, then the vitreous won't come out. And also your round hole will stay at this size. Okay, it will not stay eventually, as you see, but we didn't lose any vitreous, which is not bad. So, we will continue. How we continue now? Any options? Are we going to leave it and then tell him to come another day, send it to someone else? This is, any comments? How we continue? Are we going to clean the cortical? Are we going to do an IA? Yeah? Good, but there is no vitreous at the moment.
Yes, but it will come when the disco go out.
It may, yeah. Of course, a posterior approach it's better. That makes Thanasis Vakalis happy because that's what he wants to do. But I agree, that's a very good point. But at the moment, we're still judging.
So we've got a few more suggestions down here.
Yeah.
So
Another suggestion?
oh, yeah.
Paris.
What I sometimes find, if there is no vitreous, what I sometimes do is to withdraw the irrigation and fill the eye with viscoelastic and use only the aspiration. So I aspirate, I take some of the cortex, and then I fill in again. It's a quite sort of a slow process.
It is what we call dry aspiration, which is extremely helpful. I think it's worth trying that. And
It really depends. This is a soft matter there. I mean, it's not that dense of a vitreous, isn't it? Am I right? So you can just do
it is just soft matter, yeah. But
if it was a hard one, then well.
if it was a hard, it makes sense. It will be the next video. But now it's, that's what I said. I thought, forget about doing a dry aspiration. Let's try to keep everything down. So I put my bottle down and then do it very, very carefully without pulling too much. Yeah, okay. So.
What about a posterior rexus? Are you going to look at that, or is it?
Sorry?
What about a posterior rexus? Are you going to look at that?
There's another video.
Okay.
In this one, I wasn't too, I didn't feel that I would like to do a posterior in this one because it was actually too much in the periphery. That's what. But even if it was, in my thoughts, I would still need to clear all the soft lens matter before, at least that's what I do. I would rather finish the IA and then finish up the rexis.
Well, sooner or later, you will have to do that anyway.
Yeah.
So better sooner.
So I think it wasn't a clearly very, very successful irrigation aspiration. As you can see, it takes a long time. So maybe it might be better next time to do the standard dry irrigation aspiration. So now I move to Paris' suggestion to put some viscoelastic and then slowly. In that case, it's so stubborn that I use a little bit of phaco to take it out. But please don't do this maneuver because if you press the phaco too much, then everything will come out. So you have to be absolutely careful that pressing it is like that you have an egg between you and your pedal. And if you press too much, you will break the egg. So just take this phaco and then get rid of this matter, which is very, very stubborn. This is a matter of discussion. Okay. So we end up. What kind of lens are we good? Now, there is a bigger hole, still no vitreous. What kind of lens? Oh, sorry. Okay.
So can I ask what lens were you going to implant?
Well, for me, if I have a large eccentric tear, or say, it's not a tear now anymore, it's a kind of eccentric posterior capsulorhexis, I would put the lens in the sulcus and use a three-piece IOL. If there is any chance of having a centralized, as I can show you in another case, centralized posterior rhexis, then I might think of putting it in the bag. But in this case, I play safe, so I just put, I don't know, other options.
I think one thing that needs to be clear for the audience that what you want to avoid is ending up with a in the bag lens, either in the sulcus or part in the sulcus, like optic capture, because optic capture is great, but leads to long-term complication. I've seen lots of patients with pigment dispersion glaucoma, because the lens was perhaps just the optic in the capsulorhexis, the optics out, or vice versa. And I've seen recently a very interesting case, I should have brought it here, of UGH, uveitis glaucoma hypertensive syndrome, which was a chap who had an SN60WF implanted, just one optic was outside the bag 5 years before. We discussed at length what to do with him, and we ended up leaving him, even doing a post-Yaga capsulotomy 2 years later. And then 5 years later, he comes back with UGH syndrome. So we had to go and remove the lens, exchange it for a sulcus. So I think you did absolutely the right thing, which is go for a 3 pieces lens, because if you end up with any part of the lens in the sulcus, there will be much less risk of long-term complications.
Bruce?
So I think we're all agreed that a plate haptic is a bad idea, so that's what you're going to put.
This is also with, this lens that I'm talking is not plate haptics, was an Alcon SN60WF. So any lens that is not for the bag can lead to serious problem in the long term. We don't follow the patient long enough to see those, but if you do, you will see pigment dispersion, UGH, etc., etc.
That's with a haptic outside the bag, right?
One haptic outside the bag.
Okay, so we're all agreed you're not going to put a one-piece lens with a haptic in the sulcus. So no plate haptic lenses, no one-piece lens with a haptic in the sulcus, but you've got some options here. You could just implant a one-piece lens in the bag. And it's surprising how well that works. Supposing it doesn't work, so you're then in the posterior to your nicely centered rexis, another option is to buttonhole the optic anterior, leaving the haptics posteriorly. That works. Well, look at David Wang's video of that if you haven't seen it online. And the third option is exactly what you've done, which is to put a three-piece lens, sulcus placed, and I think the optic, is that going to go through the...
Yeah.
Right, we're going to see that
exactly.
just now.
Yeah.
Okay, so
I really like sensor lenses because the Alcon 3-piece have a bit of a higher vault, and I don't like it particularly in these cases. So sensor are a bit more flat, so I will use that. So somehow we agree in a few details. Let's go to the next one, which I think here the thing was not the rexis, as you can see, but further down, let's skip this. There's no point. Okay, so I start. It's a very, very hard lens. So I need to continue with, after doing, let's start from the beginning to understand how hard is this lens. So it's my first job. Lucky enough, it is quite good, not great, but quite good. The second job even better, so I feel more confident. I think, okay, it's a hard lens, but we're going to skip off any mishaps this time. Of course, it's this type of lenses that always the sender is hard, with this difficult to chop, difficult to separate material. They usually come from special areas in Greece, like Ptolemaida, or from Evros, or from... it is the Friday afternoon lens, Solon. You know that better.
I know, but the problem here is not just it's hard, like the chewing-gum syndrome, as I call it. It's the deepest thing, which is like...
The deepest is stuck. Yeah, I cannot separate it. But anyway, I managed to do it, but there is this. So I was in a good mood, so I did posterior rexis in this. I can easily leave it for a YAG. I just show it for the sake that if you're doing it very carefully, the rexis, you end up with a small one, and then you can use any type of lens in the bag very nicely without the need for any YAG post-op. I know. Everybody will say, come on, this is a show-off, this is not a video. But I think it does have a point when you're operating this kind of posterior, this kind of lenses. What do you think?
So just perhaps...
But I didn't like the choice of the lens. This was a poor choice of lens. This lens is quite soft. I would rather use something more, less elastic, let's say. I was lucky enough not to end up with the problems, but look, the dancing of the haptic, which I hate. And I thought, okay, this was a nice video with a poor selection of a lens, as you can see. I would rather use an Envista Bausch & Loeb, which I usually like to use. Anyway, posterior rexis, anterior rexis, everything is there. Any suggestions?
Well, it looks great at the end. That's the key point.
Looks better.
just going back a couple of steps and emphasizing some of the points from this video and your last video, you get the break. And I think one of the key things is recognizing straight away when you've got a problem. And so the sooner you recognize a problem, the easier it is to deal with it, right? So that's point number. You recognize it straight away.
Yeah.
And then you've got some choices. And I quite like this idea of trying to prevent a chamber collapse, so keeping the irrigation in the chamber and introducing the viscoelastic with your left hand. A little bit tricky to do, but it's...
Yeah, because the left hand goes like that when you're losing the capsular
I think you can all
rexus.
see the logic that if the vitreous hasn't already come forward, you don't want the chamber to collapse at that point. And then you've got the choices with how you remove the remaining lens matter. And what you've shown us there is quite an aggressive approach in some ways. If you were teaching a registrar in that situation, you probably say maybe stick to something like the dry aspiration strategy where you're using viscoelastic and minimal irrigation, so you're not having fragments flying around and possibly going down the back. But so that's certainly one possibility there. Another possibility is something called visco-expression, where you're using, rather than the phaco piece for those difficult bits, there's no law against expanding the wound a little bit at that point and doing something really old-fashioned and just removing the nuclear fragments at that stage.
True.
But before you get there, I think you can always look for this posterior rexus. So this is kind of, I think you call this an elective posterior rexus, wouldn't you?
Yeah.
There are some times when it's a bit less elective than that. And do you have, I was going to ask Vincenzo and you, Miltos, do you have any tips for posterior rexus technique? Do you have any special, do you use a particular viscoelastic or have anything that you think that would make it a bit easier for you? Do you inject it through the hole first a little bit, or what do you do? Yeah, just perhaps you first.
What I'll do is that if I have the luxury of electing it, I make a little nick close to whatever looks thicker in the capsule, a little nick. Then I put viscoelastic behind, but I don't want to overpump it with viscoelastic. And then I grab the standard. You need a kind of rexis forceps which are a little bit tilted downwards, because if you get a flatter one like the coaxial capsular rexis forceps, they won't go so deep. So Inamura forceps probably are better for this kind of maneuvers. So you go a bit deeper, you pick up the capsule, and then gradually. The other thing is aim for small in the beginning, because if you aim for too large, you may end up too large. So make for something smaller just to get rid of the visual axis problem and then continue. That's my tips, maybe.
But
I presume yours are much better.
But a cohesive viscoelastic, right? Something like Helon, is that what you use?
Yeah. For behind the capsule, I use something like Viscot, so that it will stay there. It won't disappear.
You made an important point that's worth emphasizing there. That's don't overfill. Think about the tensions on the bag. So don't either at the back or the front do too much in terms of viscoelastic.
You need flat.
Filling.
You don't need to overfill it.
I think that's the point I was to make, is one temptation is overfill the bag before starting your elective or non-elective posterior capsular rexis. But if you think that you're dealing with an inverted anterior capsular rexis, that's the last thing that you want to do, because you will make the posterior capsule more convex towards the vitreous, and the tendency to run out will be higher. So you don't need much viscoelastic in at all. Like Milton said, once that you make little viscoelastic in the bag, once that you make your cut, then inject a little bit of cohesive, but very little, to keep the anterior hyaloid, which hopefully is intact because you've not touched it, away. And then you can just complete your rexis. But the tendency is to overfill the bag, which is a mistake, because you're doing exactly the same that you do when you do a rexis and you underfill the anterior chamber. So not overfilling. Just one final thing, going back to the capsular rexis. I think one thing that I teach all my trainees is when you do your capsular rexis, before you start, look at the pupil. Because what happens, and this is the commonest cause of an anterior capsular tear, we don't look at the pupil. So we've got a large pupil, and we end up with a large rexis, which normally the large pupil are more common in young patients, high myopes, and these are the rexis that will run out. So if you've got a large pupil, you want to keep the rexis small, because it will be large, because the pupil is too large. If you've got a small pupil, just keep at the edges. So always look at the pupil before deciding on the sides of your rexis, because that's, I think, is a good thing to do, because then you end up with a regular size rexis in a small pupil and in a large pupil, and you avoid the problem.
Paris.
Usually I avoid these macho things.
I wouldn't expect anything there.
The thing is that, would you ever consider of doing this elective posterior capsular rexis after you put the lens in?
People do. I, frankly, like you, I don't do many elective posterior capsular rhexis. If there is huge amount of, thickening PCO, I may consider that. But the safest thing is always take the lens in and then do a YAG capsulotomy a few months later. You don't need to wait that long. Some people claim that by putting the lens in the bag, you actually stabilize the posterior capsule, the easier to the rhexis, but I've never done it myself. When I've done it, has always been either non-elective, or there was a time in my life when I was younger and I was doing many of elective posterior capsular rhexis, and that I was doing without the lens, but without overfilling the bag.
It's an interesting, I would like to announce that we will have a whole cataract course in January, together with the North Greece and the Hellenic Society of Cataract and Lymphatic Surgery, a whole 2-day course. And then I will show you a lens, a case that it wasn't an elective posterior capsular rhexis, but I inject the lens, everything was fine. I was routinely clear up all the viscoelastic behind, and then talking as well, which is my bad habit. And while talking, I just, managed to penetrate, to just make a posterior capsule tear. And then things really get wild when you do a tear and you have an implant and you have everything. But it's pretty difficult to try to save this thing. Once you tear it and you have the lens in, the tear just goes everywhere because of the tension of the haptics. So yeah, they may do it, but these are Indian super surgeons. It's not me, definitely not me. So let's go back. Another, as I say, white and red cataract, the kind of, as I say, the champion cataract, the same as Olympiacos, white and red. These are the cataracts that you don't like. Yes, we may have black and white now because we have a championship, a champion here, but this is only, temporarily. Anyway, so we go, everything. I try to do vertical chopping. I try to do whatever. It's hard and difficult to chop. Any comments up to now? One thing is forget chopping and do a groove. Yeah, okay. That's one comment which I agree. I accept. Any other comments? Until disaster happens? Soon it will.
Be patient.
Be patient, okay, yeah. That's a good thing. You only have another 9 cases following this. So, yes, I was patient and listening to my favorite music and saying, okay, this is another cataract coming from Ptolemaida. Okay, why don't they do it earlier? And as I go deeper and deeper, I go into deeper problems. The thing I want to show you is that if you realize the problem very early, then you may be able to have a chance to solve it. Having said that, last week I realized the problem quite early, but I couldn't save it. But things just happened as the Murphy's Law. Anyway, so break it into 2 pieces. Everything goes nice so far. Yeah, yeah. It is even worse than the other. They're like plastic. They are just attached as you go deeper. So now I'm getting a bit more aggressive because I'm losing time. So when you get aggressive, you expect things to happen. So I go too much in the periphery. There's no point of going that much in the periphery. Breaking it. Breaking it a bit more. Here it comes. Up. What do you think? This sudden change of the anterior chamber actually shows that something is lost. You have lost a little bit of your support. So now I realize, and now it's even more obvious what happened. So stop, viscoelastic, a bit more viscoelastic from the center, and I'm ending up with this. Change of plans. Usually at that time it will be good to leave it and call for the cavalry. But sometimes you may save it. How? Are there any options that someone would like to do in order to change and save this lens before ending up in the vitreous? What do you think? it will end up, maybe. So now you have a whole hard lens, and you have a hole where you
So the
shouldn't
lens
have.
hasn't gone back yet, right?
Not yet. Not
Okay,
yet.
so could I be a bit cheeky and take over here and ask Paris to come up to the stand and
Yeah,
tell us from
Paris.
the VR point of view, which would you rather we did with a lens this hard? Would you rather that we did
Just
a
throw
big
it back.
extra capsular incision, maybe what I would do here if it was like a lady who in her 90s doesn't want a second surgical session, I would certainly go round to a 12 millimeter scleral pocket at the top, put in a Vectis, pull out the lens, and do it the old-fashioned way. But I want to ask a VR surgeon, a professional VR surgeon, what should we do? Should we let the lens drop and let you handle it?
I will just have the video playing so that we will discuss about, yeah.
Yeah, well, unfortunately, I come from a generation that I haven't done that many echis. So it is much easier to me to carry on till I drop it, if I drop it, and then convert it to a planar vitrectomy, rather than put a, do a traditional echi. And sometimes it's less traumatic as well, at least in my hands. So definitely I would give it a go. I would try bit by bit to save it. If not, then I just convert it to posterior vitrectomy.
So if I've heard that correctly, you are quite relaxed about me phoning you up and saying, Paris, I'm afraid that I've put the lens in the vitreous. It's there was a time when
Solon,
then
you'd
when
like to come up
people
as
would
well.
say if the lens is really hard, you're giving us a difficult job. But David and Paris, David's shaking his head there. Paris, you're happy to phaco anything in the posterior segment now, are you?
Well, I mean, phaco now with it's much quicker, much easier. Technology has changed. I mean, we are more relaxed, and this is our job anyway. So I mean.
Another way is that we are surgeon. It's a very bad thing to have a big incision. It's very badly sutured. Go back and do the vitrectomy later.
Good to see. Well, this is really good news. This is really good news. So for my 102-year-old grandma with the lens there, they can come right along and have a.
I think that
It's a two-part procedure, madam.
But also there is another option, you know. What I did try to do here is very low aspiration, not so low vacuum, and viscod always behind the pieces. So I do a little bit of phaco, eat a little bit, and then trying to get these little pieces, where they're not so little anyway, try to get them in the anterior chamber with as controlled as possible. It's a little bit like dancing, that you're dancing without the girl somehow, but you can still dance alone if you want. So you just take the whole thing gradually. Now you can see that the pieces can be rotated. But very, very slow, with very low aspiration. Keep the fluidics in a normal, as normal as possible, and avoid any sort of loosening the anterior chamber. And somehow, as you can see, we're still managing. And once I can see, I told it visco-assisted phaco, so once I can see that one piece is out, so I'm very happy. Then I put some viscoelastic behind the other piece and trying to get it also into the iris plane plus, or let's say into the anterior chamber. Again, very, very slow, as I told you before. I'm pressing the phaco pedal as if I have an egg between my foot and the pedal. So I'm pressing it just a little bit of phaco, nothing more. Because if you press too much, you will get deeper AC, you will get more power, and you will lose it. Sorry?
Not just pressing slowly, but
Not pressing, just. Yeah, the bottle is down anyway. I said that the bottle is, irrigation is down, aspiration is down, a little bit of vacuum. Yeah, so try to keep the water just in the anterior chamber. And using the viscoelastic to save it. As you can see, even this quite troubled case can be used, can be saved, let's say, or can just save some time before the VR surgery.
That's amazing surgery. It's on an
Well, it's an amazing complication, but anyway.
On an epinuclear setting, is that super low vacuum? Is that what you're doing?
Sorry?
Yeah. Is it super low vacuum? Is that what you are doing?
It's super low vacuum.
Yeah.
Super low vacuum.
I mean, again, I'm going to ask the VR surgeon here. You're watching this video. You're worried about vitreous traction, right? Is that right or not?
Well, there's always a chance to pull vitreous. The things that the more visco you use to push everything back, then the less chances of grasping vitreous. But I think that probably if you are having vitreous in the way, that's the time to do a anterior vitrectomy anyway, and probably use triamcinolone to make sure that you can visualize all the vitreous. And sometimes that's what I do, and then I carry on with removing the rest of the cortex.
And of course, this is a 3P lens in the sulcus. Okay, there's no posterior capsule in this case. And let's end up with a traumatic cataract case. Young man, he has his son's birthday. Someone just break a bottle, and the bottle managed to cut the cornea, cut the lens, cut the iris, cut some zonules, as you can see. Yeah. I don't know why the text is not there, but I'm sure I put the text. I'm still trying to learn editing. As you can see, while I was doing the capsulorhexis, I'm trying to avoid this area as much as possible because there's a tear there. What are suggestions? We have a tear in the anterior chamber, a white lens, not a white red, but a white lens, a tear in the iris, and also some broken zonules. Any suggestions from the...
So this is a trauma case, right?
Trauma case, yeah. He had a bottle, a piece of a bottle in his eye. What do you think? Any suggestions of how to complete...
The anterior capsule tear, was it there or it happened?
It was funny enough, if there was a tear, where you can see here, there is a tear. It's not brilliant edit in the video, but the tear is like that. Somehow didn't...
So can you see the edge of the tear?
Yeah, I can see the edge. Yeah.
Okay, so it's complete.
It's complete. I'm just starting from the opposite side and then just connect the two ends to the tear. Yeah.
So I think the strategy would normally be to do as much of a rhexis as you can, leaving the tear where it is, and proceed with the phaco. Is that right?
Yeah, that's why I did as big as possible rhexis, and I'm afraid Vision Blue is not helping that much. And then, what about the lens? What are you going to do with this lens? It's a 30-year-old, had a bottle, just broke, cut the cornea, cut everything. How are you going to remove this lens matter? Yeah, aspirate.
It's going to be soft.
Yeah, going to be pretty soft, isn't it? Yeah,
it is very soft, so I just use irrigation aspiration. You can see now I'm ending the capsulorhexis as big as possible, and then just irrigation aspiration. Keep everything again low. Here I have a bit more patience, Solon, not like the other one.
So, Miltos, if there was a peripheral tear in the anterior capsule, then would you consider of doing a more posterior capsulorhexis, ignoring or avoiding the edge of the tear?
Not to connect the two areas. Yes. Just leave one tear on one side. It is interesting, but if it was on an area that I'm sure that I'm not going to... I mean, if it was a tear somewhere there, I might do a rhexis that side and continue. I don't know. I haven't this case. If I have it, yes, I will consider. Did you have anything to suggest?
I think the advantage is do this case early when they are soft, because the real problem is if you're dealing with a really brunescent cataract, like one they showed before, there will be much more forces inside the hemorrhage chamber. So do them early, this post-trauma, and like you said, keep the sort of gentlest setting of the phaco machine that you can, because you want to avoid infusion, you want to put pressure on tears, zonula, anything else. And luckily, there is no risk of corneal decompensation here because the lens is soft, unlike the previous one.
You can see that there is some hemorrhage probably behind the capsule. And I feel so happy that I'm ending up. What kind of lens are you going to put?
So can I ask the question, is immediately after the trauma, or was this an injury that happened sometimes?
About 4 months post-trauma.
Okay, so we're not worried about endophthalmitis after the injury anymore.
No,
Okay.
about 4 months.
And do you have any intact posterior capsule? Just
Yeah, for change, I have an intact
broken
posterior capsule in
anterior
this
rexus,
case.
though.
Yeah. I can find the case, you know, with intact capsule.
Yeah.
If I try hard, I will find one.
So one approach here is to put the haptics of the lens at 90 degrees to the tear and do a relieving incision in the anterior capsule opposite. So you have two equal halves, and that avoids lens decentration later from asymmetric contraction. But other surgeons say, look, it makes no difference doing the relieving entry on the opposite side. This is something that I picked up from Graham Barrett, who told me to phaco back in the day in Australia. We used to get the patients back for long-term follow-up in those days, and you would see asymmetric contraction occasionally, and that was his solution. But I think you've actually got a tear right the way across.
Right away on the other side. Yeah.
So you've done it already. That's great. So
Yeah.
haptics at 90 degrees. How about that?
Yeah.
In the bag.
It is. It was really very
pieces.
challenging, and it's getting worse when I put the lens in, and the haptic is twisted. So, you know, it's getting really worse. The day starts difficult, it gets even worse. What to do next? So you have a tear, you have a lens which is twisted, semi-inserted.
If you think that haptic is kinked, rather, I mean, in other words, it's not going to recover the shape, you take it out and start again.
Any other options? Well, it's fully inserted, not yet. Yeah, quick, okay, yeah. You know, sometimes the materials are quite tough. So I decided before enlarging and taking this lens out and start cursing myself for whatever I use, why couldn't I try to rectify it in the eye? You know, sometimes you have crazy ideas that you can just straighten it. So I use these funny forceps, trying to identify where the problem is, and the problem is somewhere there, and say, okay, the worst thing is to break it, but let's fix it if we can. You can see it didn't break. I thought it would break, and then I have to do the plan B, which is taking the lens out. So funny enough, it went really nice as a configuration which I like, and then I said, okay, let's continue and put it. But of course, this haptic, I would like to have it on the top and not on the bottom. But at least I will have a haptic. So, what do you think? Was it a foolish thing to correct it, and then I do some iridoplasty, because I think if I have done the other thing, then iridoplasty would work as well. So let's finish up with iridoplasty. What do you think? Is it going to be there? At least this is 2 years old, and the lens is staying there. So the history is that so far the lens is stable. What do you think?
Great save, again, you know, amazing.
I've seen something more interesting. I saw an Indian guy, the haptic was off, and then he took it inside the AC and put it back into the tunnel of the optic. I couldn't believe it that happened. When I saw that, then I said, okay, everything can happen. So then I have this kind of complication, and I try to do it that way.
You know,
Yeah.
there are risks in removing lenses, so sometimes you take a judgment if the little damage of the lens is bad enough to justify the exchange, or if you can get away with it, like in your case, that happens with all lenses, and this is always difficult, but it's only based on experience and what you can achieve intraoperatively. If you were to remove the lens, how would you remove it, Miltos?
In this case, well, with all the bad happening behind the lens, I wouldn't make any funny cuts. I will just enlarge into 5 millimeters and take it out. But if I have some sort of good capsule behind, I may try to cut the haptics, cut the lens into 3 pieces and then rotate it. But there is no point in this particular case to do the funny
because
things.
One interesting thing is differentiate between the material of the lenses, because hydrophobic lenses are really easy with the proper technique to fold inside the eye and pull out. You cannot do that with silicone hydrophilic, but with hydrophobic it's relatively straightforward, so it can be done quickly. You avoid wasting time, because we all know how difficult sometimes it is to cut the lens inside the eye, and you can pull them out. But it's only easy to be done with hydrophobic
Vincenzo, with
lenses.
hydrophilic, if they are not super thick, you can enter your standard forceps, but just enter them behind the center of the lens, grab it, and take it out. Hydrophilic somehow are more, let's say, plastic to do it. But with a hydrophobic like this, with the haptics going anywhere, I will be reluctant. And with the capsule that usually stare into 2 pieces, I'm just looking for trouble if I'm trying to save it like that.
Great. So if we've got time for one other tiny scenario, really quickly, so since I've got you on the stand, we covered quite a lot of the problems that you can commonly see in cataract surgery. But there's one question I've got for the VR surgeon. I'm already really relieved to hear that we can drop any lens back now, and that's good news. So, but another scenario here is you don't do a great save, like maybe the lens goes right back, and so at that stage I would tidy up the cortex. Now, as a VR surgeon who's going to get the part 2 of this 2-stage procedure, madam, do you want me to put a lens in at that point, or would you rather I left it for you to do later? Is it going to make the VR surgery more difficult, less difficult, or just the same if I put a lens in? So it gives the patient a quick visual gain if I do put the lens in, so they're less unhappy, but then I don't want to make your life more difficult.
The question is that you have already removed the IOL.
So the lens has gone back. All right.
Okay.
It's good.
So it's different than this. Okay.
Yeah, sorry. It's different than this. So the hardened nucleus has gone back. Okay, it's
I
good.
would rather leave it alone, and I put the
you
lens
put the
later.
implant in.
Yeah.
Thank you very much.
I don't know, David. What would you prefer?
I think the thing that makes it hardest to the VR surgeon isn't the nucleus or the aphakia or anything. It's the corneal edema. And if you've got an edematous cornea, and remember, very often the VR surgeon is going to be doing this the next day. It looks great when you're doing it. By the next day, you can have quite a lot of striate keratopathy. And so what I plead with everybody who's doing this is if you think that it might go back, then please stop. Do the least you possibly can inside the eye. Look after that endothelium and keep the cornea clear and send it to us. Because then it really is an easy operation. And if you haven't had the chance to see that being done, it's well worth doing it, because going along and watching a VR surgeon do one, because then you'll stop worrying about it. You'll push them all back because it's so easy. It really is straightforward.
Maybe if I can just as it's for the sake of the discussion, it's easy even if you have a long-standing, like we're doing all this of funny endothelioplasties, DMEC, DSEC, whatever. For us, this is not a big thing, because if you take off all the epithelium and leave it, put a bit of air behind the cornea and leave it for 5 minutes, then you will have a brilliant and clear cornea. So that may help. Of course, it will end up with a DSEC later on, but if you do this, you will have at least a clear view. Epithelium is usually the cause of the bad view. Do you agree? I think, Vincenzo, you do most of the time the same.
I think I would agree that the striae are going to be a huge problem apart from the epithelium, because that will make the visualization of the VR surgeon much more difficult. Having said that, I would say I shared Bruce's sentiment, which is if you feel that you can do a decent incision, not a poor one, a two-step, and you can remove it quickly, with minimize the traction on the vitreous, then you've got an option. Of course, there are risks with that option, because one thing, especially in a 90-year-old, would be the risk of expulsive, which I've experienced too, and the only two that I've experienced were during extracapsular cataract surgery. But going back to the case, I think, like I did say in my talk, just with those cataracts, there's only one thing that you can do. Go deep in the center as much as you can until you see a red reference, and only then try to crack them, because otherwise you won't manage, and huge rexes as well, because sometimes the tear starts from an anterior and then becomes quickly posterior because of the maneuvering.
But did you notice that in this case, case number 3, it actually happened when I cracked it? I just overpressed the crack, and then suddenly I saw a sudden deepening, which is...
I'm surprised.
Okay, I understand that we have to change. Okay.
But another thing that happens often is that you weaken the zonula, because you keep on doing this movement, which is... and you do it more than we all should. We do it more because the lens is harder, so you stretch it more and more. So sometimes what I've seen happening is posterior capsule is intact, but the lens just tilts because the zonula has gone on one side.
Great. Thank you very much, guys. And let's move on. Okay, one last thing, yeah? Sorry, I can't hear you. I didn't.
But you did some sort of hydrodelineation, I guess.
Sorry?
You did hydrodelineation, though.
In the last case, I did nothing.
So how it...
It is a case with IA. There's no reason. There's no reason.
So just a really quick word on that, though. If you're asking, do you hydrodissect if you have an anterior capsular tear? For me, the answer is yes, but I understand the arguments both ways. If you do hydrodissect, then subsequently the lens movement is easier and it's less traumatic to the capsule. If you don't hydrodissect, then you're not risking an extended tear as you hydrodissect. So you have to form a view of this.
Yeah, but if you do hydrodelineation, though, then at least you have some mobility. And
but then you have the epinucleus stuck.
The reason I didn't do it was because I did IA, so there is no point for doing it. If it was a harder lens, then I would hydrodelineate only and then take rest. The first challenge, me and Vincenzo.